Hey, I think we got it. Hello, hello, hello.
Hey, John.
Hey, Ryan, we got it.
How are you?
Very good.
Well, that works pretty well.
Well, good. You see, the camera okay?
Yeah, yeah, looks great.
Okay, good, good. Let me. I want to see if I can put my label up here. For some reason, I changed screens. If you want to put your, you want to put your label up there?
Yeah.
Okay. Just you know how to do it, right?
You know, I'll
Okay, go to the far right. The far
yeah.
right upper under. Well, first open the toolbox,
Yep.
and then the far right, the first icon is like a head.
Okay.
You got that open?
Here we go.
And it'll have the lower third. Lower third. Put your name, and then put a tagline underneath what you want to be before under your name, like West Urology.
Yeah.
Okay. And if any, you want to put any icon there or anything like that. And then any color, well, if you want any color. Now, if it's backwards, like it probably is it okay on your screen?
Yeah, I'm seeing yours. Yours looks good.
Okay, okay, let me, yeah. For some reason, my camera's low today. We'll get on. This is our maiden voyage.
Well, I'll tell you what.
You can't see any banner. Oh, I can see your banner.
Oh, can you?
Well,
good. Yours looks great.
I'm just a little slow here. Oh, you see the banner?
Yeah, I can see yours.
Backwards or okay?
No, it looks good.
Oh, okay. Okay. All right. We can start. This is the first. This is the maiden voyage, the first robotics, medical robotics talk between Dr. John Bennett and Dr. Brian Stork. I'm from Miami, Florida. Brian's from Muskegon. Let me just talk a little bit, Brian, first to explain what we're doing here. This is basically a Google Hangout series. We're using this platform because we feel it can help communications amongst doctors and patients. And the way we have it set up, Brian and I are going to talk about robotics tonight. I'm going to give a little introduction, and then maybe we'll ask for some questions, and then Brian will take over and do the bulk of the talk about his history with robotics. And then we'll answer questions if anybody has any. There's a tweet board to the right of the screen, if you notice. You might have to, if you click tweet, you might have to download the program Twubs, which is safe. Or you tweet from your own tweet board to the question to the hash mark Robotics Weekly. Do you want to say hi, Brian?
Hello. I'm honored to be here, and I'm glad that Urology is getting the first crack at Robotics Weekly.
Good, good. I hope it goes for a long time. Okay, I was fortunate enough, I'll start now with just a general introduction of what robotics is to me. And I'm a newbie to robotics. I just know what I read in the last couple of days. I was fortunate enough to get a file from Andrea Colo. He's a PhD from France. He's doing research in robotics. He was nice enough to send me a lot of what I'm going to tell you right now. So let me just go over briefly. Okay, this first slide. Oh, I don't even have screen share on. Oh boy. Okay, well, I'm a rookie. Let me get one here. I was going to the screen myself, which is fine. That would have been very. Oh man. Okay, screen share. Okay, coming up. Okay. 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 Okay, Brian, are you still there?
Yeah.
Okay, I'm still trying to get the screen share out and having a little trouble. Okay. Next lecture. Okay. We're getting there.
There you go.
Let me know when you see. Okay, good. Okay, as I said, Andrea Colo sent this PDF file, which gave a pretty good introduction to robotics. They have a big robotics center over there in Montpellier, which is in the south part of France. It's a picture of the center. That's where the location is, south of France. They do a lot. I was really surprised, lucky to run into this. They do a lot of robotics research. Okay, here's basically the timeline of robotics. I guess it started way back in 1985. It actually started, Brian, I'm surprised to find out, it started with neurosurgery. They took the initial crack at it. And as you can see from the diagram, they did some more type of work with a different type of robotic device, I believe. Then orthopedics took a crack at it. I can't tell you what these initials stand for. And then, Brian, way back in '91, I guess you guys took over with the transurethral resection of the prostate back in 1991. The Vinci was started, which is the dominant machine that seems to be around the urological ORs today. That was initially started in 1998, and the pill came in 2001, and transluminal endoscopic, which we'll go over what that is. Okay, so this is a brief overview of surgery. General surgery, there's traditional surgery, of course, with the scalpel and everything else. Then it came to, I believe, and correct me, Brian, if I'm wrong, minimally invasive surgery, which I believe is laparoscopy, where it's just one probe inserted into the cavity. And I guess Brian will talk later about the advantages, disadvantages that robotics has over laparoscopes. Then it went to endoluminal surgery, which is inside the vessels. In the future, they think that there might be possibilities of doing surgery on fetuses. Well, I don't think much of that has happened today. And eventually, when miniaturization, the microscopy gets very small, surgery on the cell. So, okay, here's an example which was pretty surprising. This is called intra-body robotics, where the patient will swallow a pill, and there's actually a little camera inside the pill, and one can just imagine the possibilities there. And those are actual images shown by the pill. So, and it seems like the resolution is pretty good. You'll be able to spot some pathology, but I can't begin to try to guess to interpret those films. Okay, next is the it's another intra-body robotic, which is quite a little machine. Apparently, you can do sense. You can do not only for photographs, but sensing, which is of course wireless, and it goes to another device to be interpreted. And this Brian, I was surprised. I read about it tonight. this was a transatlantic operation done. It's called Telesurgery. It was done by French physicians in New York. They operated through a robotic machine with a patient in France. That was quite extraordinary. And the Army has worked a bit, I believe, in San Francisco with a private firm to develop telesurgery and robotic type of surgery, because they feel they can do quite a bit of surgery in the field with wounded troops and not put doctors and other personnel in harm's way. And lastly, here, Tele-Diagnosis. That's when they have a portable machine that goes around. I believe some ICUs have it. I think at Stanford they actually have these today in the ICU, where the patient the doctor can communicate with the patient in the ICU or wherever. And before I turn it over to Brian, there's just one book. I haven't seen this book, but apparently there's a book available called Medical Robotics through Wiley. So, okay, I'll bring it over to Brian.
Well, that's a great review, John. I looked at those slides earlier today, and they did a very nice job of reviewing the history of robotics. I could probably speak more to the history of robotics in urology. I have to say, though, that the endoluminal camera those pictures were fascinating, and it looked like, I can't speak to it because I've never seen it, but it certainly looks like they can control it. It had a motor on it, I noticed.
Yes, I think they can.
That's amazing. But robotics in urology started, as you alluded to, with this device called the Probot. And the Probot, as I understand it, I never saw this device, was a robot that could do a transurethral resection of the prostate. So, it's very common for men to have enlarged prostates. One of the surgeries that was routinely done in the past was a transurethral resection of prostate. And some surgeons in London developed this robot to be able to do the procedure. I don't know what happened to this robot. I've never seen it. I sent out a tweet this morning to the guys in Australia and England, and I never got a response back. So it certainly doesn't seem like it ever really made it to the mainstream, like the Da Vinci robot that you alluded to earlier. I can tell you that when I was in general surgery, when I was training in general surgery, they had a device called the ASOP, which was basically a way of having the surgeon have his own assistant or be able to control the assistant during the procedure. So it was a robotic arm that was voice controlled. I saw this in action a couple times, and I thought it was a very useful tool. I don't see it used anymore, probably because the technology has advanced so much. But I thought that was a pretty interesting piece of equipment. It seemed to work well for gallbladders when I was doing general surgery. One robot that was mentioned on your list was the Zeus, and I saw the Zeus once at a conference. It was a big machine. It was the forerunner to the Da Vinci. Ultimately, Intuitive Surgical, the company that makes Da Vinci, bought the Zeus technology, and I don't think Zeus ever really caught on real well, but it was a pretty sophisticated machine, as I recall. Mm-hmm. Robotic surgery in urology, most people equate it with prostatectomy. So I was training in Beaumont back in 2002, and the guys down at Henry Ford for a couple of years had been perfecting this robotic prostatectomy. Prostatectomy can be done open, it can be done perineal or underneath the scrotum, and it can be done laparoscopic. But laparoscopic prostatectomy is a tricky surgery. There's a big learning curve associated with it. There was a group in France that was able to really perfect it, but it wasn't transcending very well into the community, and even academic centers in the States were having trouble duplicating what they were doing in France. So when this robotic technology came out, it solved basic problems of laparoscopic surgery. Mm-hmm. If you think about it, when you're doing laparoscopic surgery, you're really using basically a stick. you're using two sticks, one in your right hand and one in your left hand, to try to suture with. And so if you're trying to do some fine suturing, you know, it's sort of like eating with chopsticks. There's a huge learning curve in the beginning, and there's not a lot of flexibility at the end of the stick. So the biggest advantage, in my opinion, of the robotic technology was just the degrees of freedom, the way that you could use your wrist in a natural movement with this device inside the patient's body to do reconstructive surgery.
And the photography is better too, also with the Da Vinci, correct?
Yeah. So yes, and so in standard laparoscopic surgery, you're really looking at a 2D field. It's like watching a TV.
Right.
When the robotic device, the Da Vinci system, has two cameras on it, so when you're viewing on the console, you're really viewing the device magnified and in 3D. So it's really incredible, the visualization that you're able to achieve. I mean, I've seen things with the robot that I really only saw in the textbook before, you know.
Mm-hmm. How was it? How was the beginning, Brian? Do you remember when it first came to your hospital? What was it like? Were her surgeons hesitant to try it, or were the representatives always in the operating room? What was that like initially?
Yeah, so I can tell you, John, when I was at Beaumont in 2002, I was graduating, and we knew that there was a robot in the hospital, but none of us had seen it. It was shrouded in secrecy and mystery, and that's kind of the device had a bit of mystique to it in the beginning, because there really hadn't been anything like it that we had used before. So you can imagine trying to bring that technology into a community a few years later. People weren't very familiar with it. They didn't understand it very well. It was a bit of an effort to get the hospital on board, because it is quite an expensive device. And then we had to figure out, because we weren't residents anymore, we're surgeons in private practice, how do we use this thing? How do we provide the safest care that we can for our patients as we're going through our learning curve? Mm-hmm. So there was a lot to it, getting the robotic program up and going, and that has been, I think, the experience everywhere.
Mm-hmm. Were you allowed to train on it without touching a patient? Kind of like get you know, dry runs or something, where you just get used to the equipment and moving the arms, etc. Yeah.
So some of the training program is directed by the company, and some of it is just based on your own sense of responsibility. So we went to a training course. We operated on pigs, for lack of a better term, with the device so that we could get comfortable learning the device. We would travel and watch other people do the surgery. We'd watch videos. For our first several cases, we had proctors come in who were watching us the whole time as we were doing our surgeries. And then it's a continuous process improvement. So, you know, we continue to go to conferences, continue to watch videos, continue to share best practices. And most robotic surgeons will tell you that they're learning all the time, that you know, there's new techniques, new tricks, new equipment all the time, and it's like anything else. You just have to stay on top of it.
Is it still the majority of Da Vinci's right now today in the OR, or is it other companies also?
Yeah, so to my knowledge, Intuitive Surgical, the maker of the Da Vinci robot, is the only FDA-approved robot for what we're trying to do in urology.
Oh, it's the only one.
Yeah, so it's a monopoly, if you will.
Okay.
And you can imagine that anytime you have a monopoly, there's advantages and there's disadvantages. One of the major disadvantages is the cost of the device. Certainly, I think most urologists would wish for a competitor in the marketplace to try to bring the cost of the machines, of the disposables, of the entire surgery down. On the flip side,
right,
having one manufacturer means that everything's pretty standardized. So when we're comparing notes about how to do this surgery, we're all familiar with the equipment that we're using, because we're all using the same equipment, if you will.
Mm-hmm. Now, you're not too familiar with the other types of robotic devices in the hospital. I haven't heard too much of them. I don't know if they're being used with the endoscopic pill and that sort of thing. In your particular hospital, do you have any robotic use in, let's say, orthopedics, or I guess you mentioned the other day gynecology and hysterectomies, correct?
Yeah, so I don't see locally any robotics use in orthopedics, but we see lots of robotics use in gynecology, particularly for the hysterectomy. I think the hysterectomy numbers with the Da Vinci system have gone through the roof over the past several years. I'm not exactly sure what the advantages are of using the system, because the gynecologists were pretty well versed in laparoscopic surgery even before the robot. Some of it may be marketing, some of it may be because we're a educational or a residency center here and we're constantly training residents. I think that the use of the robot for the hysterectomy is a little more controversial depending on who you talk to. But I'd certainly have you talk to a gynecologist about that, you know.
What's interesting, you know, the PhD, Andrea Colo, they seemed, you mentioned a little bit about the French using the robotics, some type of procedure. It seems that they're pretty developed over there. He himself's working in the orthopedic arena, doing tension of the ligaments in the knee. They're trying to improve the technology of knee implants. I don't know if you know about the total knees, but in the old days, when I was scrubbing in on those operations, they would insert the prostheses on top of they would shave down the condyles of the proximal tibia, and they would eyeball it where they did the cuts, which I guess seems kind of primitive. I guess now there's a lot more measurement, and I think what his research is measuring the tensions of the ligaments to make sure. I guess they try to figure out the optimum tension to put to determine how big the prosthesis should be, and they must have done some biomechanical studies. But it seems like an interesting field, and certainly it's going to get bigger.
I think there's no question. You know, I should probably clarify, although the robotic prostatectomy is probably the best known procedure that urologists do with the Da Vinci or with the robot, it's actually probably used more efficiently for partial nephrectomies. So when I was training, or when I was in med school back in Iowa, the standard of care if you had a renal mass was to take out the kidney. Over time, the standard of care for smaller kidney tumors has been to try to remove just the tumor itself. Over time, as opposed to opening the patient up, making a large incision, we've been able to utilize this robot to laparoscopically control the vessels to the kidney, remove the tumor, sew up the collecting system if we need to, sew up the parenchyma of the kidney. So it's really a beneficial technology where you need to sew in tight spaces or you need to do reconstructive surgery. So I think most urologists would agree that it's a really effective tool for the partial nephrectomy.
Does it outnumber the prostatectomies, the use of the robotic surgery device, or is it 50-50? What percentage would you say the prostatectomies are done today?
You know, the last I read, it was about 80% robotic and about 20% open.
Wow. And it's gradually getting more, or kind of staying stable the last couple of years?
Yeah, my understanding is that it's starting to plateau, that it's starting to plateau at about that number. But if you think about it, if you have one company providing the robotics for all of those surgeries, that's a fairly lucrative market, you know.
Yes, and that's probably one of the most common operations around, right? Prostatectomies.
Well, it's certainly one of the more common operations that we do, even as community urologists. So, or maybe I should clarify, one of the more common laparoscopic or open procedures that we do.
Does anyone ever use laparoscopy anymore?
I think we use traditional laparoscopically less and less. We used to use it occasionally to do a lymph node dissection. I use hand-assisted laparoscopy to remove the kidney entirely to do a radical nephrectomy. I prefer to do that instead of using the robot. I think it just works better for me. It's probably a little more cost-effective as well. Again, the robot really works well if you're trying to reconstruct something. If you're just trying to remove something, like the kidney, you know, standard laparoscopy or hand-assisted laparoscopy are fine alternatives.
Mm-hmm. Yeah, it's been a while since I've been in the OR. I kind of don't know what's going on. I can remember everything was open. They would basically use a scalpel. But I was, you know, being away from the OR, and I think I mentioned to you the other day, I was so surprised that it was even started on a large scale basis, you know, knowing that surgeons, you know, they're not the most open to innovation. It takes a while. And I could just imagine the battles that took place in the surgery lounges and in the surgery parts of the hospital when it first started. And I'm sure it wasn't an easy battle.
Well, I know that certainly when the robots started being used in urology, that there was quite a bit of discussion as to whether there was a real advantage between our standard prostatectomy and the robotic prostatectomy. I think a lot of people are still, to some degree, having that discussion. What seems to be consistent is that there seems to be less blood loss with the robotic surgery, generally less discomfort, and generally patients go home faster. But beyond that, if you're talking about more continence rates or talking about erectile dysfunction, you're probably still going to hear quite a bit of debate back and forth. I'll tell you the biggest debate that I ever saw, and maybe you saw this as well, is when the general surgeons were debating about using laparoscopy versus the traditional cholecystectomy. That every institution I went to while I was training, that was a hot debate.
You know, I could just imagine the grand rounds in the urology, the urology grand rounds around that time must have been pretty exciting to go to.
Well, part of these debates too, it boils down to the haves and the have-nots, right? So if you have the robot, you have a completely different perspective than if you don't have the robot. So it sort of becomes a battle of technology over time as to who has what, and then what you're. You know, if you don't have the technology, you probably have a different viewpoint on it than if you have it.
Right. Well, you know, as I mentioned before, I was just surprised, Brian, at the medical robotics is more than just the surgical robot. I was surprised when I looked at there's an excellent website which there's a link at the bottom of the page at Carnegie Mellon. There's such a wide variety of research going on, all types of robotics. The robotics we went over briefly, the endoscopic and the endothelial, and they're working in some, I think at Carnegie, putting a microscopic robot inside the coronary arteries, where they're trying to basically eat away the clots or eat away the atheroma in arteries that are beginning to become obstructed. And you know, who knows where that goes? That is going to go. But anyways, so Brian, let me just briefly go over. Well, let me screen share. Once again, I forgot. Let me put the screen on so you can see what I'm doing here. It's the abstract submission. They have conferences in France every 2 years. I thought they had it every year, but they have it every 2 years. But I guess you'll be in your igloo there in Michigan. Is that your house?
That was the lighthouse down in Grand Haven I sent you that was all covered with snow and ice.
Wow.
So.
Okay, I'm trying to get.
I'll tell you, John, I think you're onto something here. I think this would be a really good weekly talk for you because there's just so much going on in this field, you know.
Oh yeah, it's interesting stuff, and like you know, I'm sure you being a doctor, maybe a doctor, I love it. I love this. I love talking about it, and I love, you know, and most doctors I meet, they love learning, any kind of learning that has to do with medicine. I'm just putting up, Brian. It's a nice section of the website I came to of that school in France, that research center in France, and these are the list of abstracts of the things they're working on, just to give you an idea of what may happen in the future. But it's a surprisingly active field, and you feel free to comment if you see something. Application of robotics and computer-aided surgeries, that's basically what we're talking about. Real-time haptic simulation. Now, haptic, what does that mean? I think I know what it means.
So haptic is the ability to sense with your fingers, to sense touch. So one of the limitations of the Da Vinci to date has been that we've taken a surgery, the radical prostatectomy, where touch was a major tool in how you did the surgery, and we've taken that sensation completely away from the surgeon. So one of the learning curve problems with learning how to do a robotic prostatectomy was you were going from using your hands to completely using your eyes to identify tissue planes. So Haptic Technology is I know they've been working on it a lot, and it's going to be really interesting when they get that up to speed, to be able to see and feel tissue the way it feels in real life while you're sitting in the corner of a room, you know?
Well, you know, digitalization has brought all kinds of things, and one of them is a science called elastography, I believe it's called, where it's the feeling of tension of a tissue, because as you know as a surgeon, when the value of touch is to see sometimes how tense a tissue is, if it's tense or loose or whatever, and yeah, digitalization, starting sciences, and there's things that actually measure the elastography, I believe it's called, of tissue, how tense or stiff it is.
Well, you know, that's very interesting. I hadn't heard that term, but when we all first learned how to use the robot, it takes quite a bit of time before you can tie a knot without breaking it, because you don't have any tactile feedback.
Right.
You know.
Is there any numbers to rely on when you tie that knot? Is there something on the?
You know, it's really based on vision, and over time, you just over time develop a feel for it, even though you can't. You don't have that haptic feedback. I don't know how to explain it. You kind of have to experience it, you know.
Okay. No, I tied a knot a few. I kind of know. But just from tying your shoes, it's nice to get some feedback, you know, if you really want to tie them tight. Okay, I'm just going through a few more of these abstracts of things we might see in the future. Image-guided procedures. Yeah, robotics has a place too in inserting lines, apparently too. And ultrasound-guided robotic surgery. Gesture.
Yeah, I think if I'm not mistaken, I saw a robotic blood draw machine a while back, or maybe they were putting IVs in with it or something. But you know, after a while, you start thinking, well, maybe surgery could be assembly lined. You know, maybe you had a robot to put the IV in, and a robot to put you to sleep, and a robot to do the surgery, and a robotic nurse to wake you up. You know, I don't know.
Well, you know, that robotic drawing of blood, it's based in Miami, in my town here. I'm in Miami, and I call that company because I want to get a hold of them and see if they want to come on, because if they're from the field of robotics. And the gentleman, the owner's son, goes to Stanford. I wasn't able to get a hold of him, but yeah. And I actually said when I had my blood drawn at the local lab, I asked the lab tech, because I foresee this coming. I think that blood drawing will be done, if not by robots, it won't be necessary at all to be drawn, because there's some stuff going on in, I believe it's called Theranos. It's a company in California that can do multiple blood tests on just getting a microscopic finger stick of blood. They can do everything.
Right.
and they actually have a contract with Walgreens across the country to set up these mini labs. I'll have to send you the link. And Henry Kissinger's on the board of that company. It's real. It's a real company. You know, I asked her, do you have another line of work in mind? Because I don't think drawing blood, the way that we know it, the way we grew up with it, is going to be around too much longer.
Well, I think the company you're referring to can do it cheaper as well.
Yes. Well, and one of the big reasons why the woman who's from Stanford, I don't recall her name, did it was because she felt that patients should have control of their lab work. In other words, the patient will go to a Walgreens, have a finger stick, and be owner of the value of their blood work. They'll be the owner of that.
Yeah.
So it's kind of taking it out of the doctor's hands a little bit there, but I'm sure there's going to be issues of self-diagnosis and, you know, going back to the computer after getting the results of the CBC back. Well, you know how that's going to work. That's going to be fun. But well, I think in the future, I'm thinking I would like to approach. Well, there's different areas of robotics. I was in correspondence with a vascular robotics person from Washington that he seemed interested to come and talk. There have been people that tell me, oh yeah, I might be interested. So Brian, if you can think of anybody that you might think is interesting, or even some other urologists that want to kind of discuss new things that are happening or whatever, some interesting people that'll be educational for the viewer, or just to stimulate discussion.
Oh yeah, I'd be glad to help you out. And we have our annual meeting in May, and I'm sure there'll be all sorts of things presented there. It's in Orlando, actually.
Oh, okay.
I don't know how far you are from Orlando, but
about 4 or 5 hours.
The AUA is at Orlando this year, and maybe if I see anything about robotics, I'll send it to you, and you can decide if you want to come up and.
Okay. Well, you know that's one area where I think these hangouts can be used. You know, part of the reason why I'd like to do this, I want to do this, is to show people that it has possibilities. And if there are people out there that want to start a vascular robotics hangout, you know, I'll be glad to set it up for you. And anybody that wants to set up any kind of health-related hangout, it's a good way to meet people, because I think if you have something like this going, it's a lot easier to invite people to come if it's already going. I'm sure, Brian, when I show this video, because this is being recorded, by the way, and it will be used in court, but if you show them, you know, guys like us talking tonight, they might see it's not so bad, you know, and they might say, yeah, sure, I'll do it. But it's hard to convince people if they don't see it or they don't know the format, what's going on, etc. But okay,
well, it's interesting to me, John, kind of having an interest in social media. I meet a lot of people on Twitter, but it's hard to have a real conversation on Twitter. You know, you go back and forth a couple times, and that's about it. I think what you demonstrated here tonight is that, you know, you can engage somebody you haven't met previously and really have a meaningful conversation using this tool. So I like it. I think it's a really interesting piece of technology.
Well, you know, Brian, I think you hit the nail on the head. It's hard, you know, when you have a website like mine and people say, oh, you've got to go on social media and chat, and you have conversations like nice dress, nice picture. They're very superficial conversations, but because they, you know, the social media people will tell you, well, Dr. Bennett, you just got to get on there and be active. And their idea of active is saying just that, just being very superficial, saying, you know, nice picture, nice this, nice that. It's really not talking. It's just a little blurb type of thing, and it's not a conversation, really. And this is more meaningful. It's more educational, and I think it certainly has a future. Now, what I propose to you, Brian. I think your blog viewers probably want to meet you and talk to you. I think it would be an excellent thing for you to say, I'm going to be at this location at 8 o'clock at night next Thursday, so come in and meet me, let's chat.
Yeah.
And they don't necessarily have to be in the panel like I am with you, but they can just be tweeting. Or you can invite someone to the panel, whatever. But and you can answer their questions live while they're talking to you. I know they would probably get a kick out of meeting you in the flesh. You wouldn't meet them, but you'd be answering their questions and stuff. And
yeah, no, it's a great idea. Because a blog is really you're really publishing something. It's sort of a one-way conversation. I mean, people make comments and stuff, but it's really a one-way conversation for the most part. Whereas this is a two-way conversation,
Yeah. Well, if you want to do it, I'll be glad to set it up. It's very easy. Because you're pretty active on the blog, correct? You post pretty frequently.
Yeah, I try to post when I'm passionate about something. So I try not to post just to post. I try to post when I'm excited about something or passionate about something. So I thought maybe my next post would be about this, because I thought this was pretty fun.
Good. I'm glad. Like we could use the press. And there's a girl that's very active on social media. I think you retweeted one of my tweets to her. She's from New York. You know who I mean?
Stacy Loeb.
Yes.
Yeah.
Yeah, she has a wonderful website for urology boards or something like that. Or it's a big website.
I'm less familiar with that, but she's got a radio show. She hosts a radio show on Sirius.
Oh, really?
Sirius 81, yeah.
Oh, okay. On urology-related stuff?
Yeah. Well, yeah, she covers urology-related stuff. I think it's their health channel.
Okay.
But she'd be great to have on your I want to say on your show. I guess on your Hangout.
On your Hangout? Well, Brian, it is. I mean, this is like owning a TV station, and you could own it. You could own a TV station too if you wanted to. Once you learn how to work it, you could invite people. You like to hunt? Well, most people from Michigan do for some reason. Do you hunt?
I fish.
Okay. You could have a hangout with fishermen.
There you go.
You could get fishermen from around northern Michigan or wherever, and you could meet like this and talk about fishing. Doesn't have to be medicine. You can make it for any interest at all. Just think of what interests you, and you're able to do it with people wherever. I really enjoy it because I can talk to physicians overseas. And, yeah, it's wonderful. Today I work a lot on my website, but I was talking, and Facebook's also another way of running into people. An IBM worker from Zambia in Africa wrote me and said, "Oh, I want to connect with the medical community. We need medical care." And I said, the first step is to have a Google Hangout with you. So I'm going to be having a Google Hangout with this IBM gentleman in Zambia, which I know needs telemedicine essentially, because they just need it. In India they have a saying: it's either telemedicine doctor or no doctor. It can't be picky. Oh, I'd rather see a doctor. No, they don't see doctors, so at least they'll get the benefit of someone seeing what they got. But anyways, this gentleman from IBM said, "Oh, I'm interested in an app which I can send doctors pictures to see what's wrong with these people." And immediately I thought of this media. I said, "You don't need an app. We just need to hook up with a Hangout." And I can see a patient just like I'm looking at you right now in Zambia, with probably the same the picture's just as good.
Right.
And if they have a problem I can't handle, then I say, "Well, I'm sorry, I'm going to have to send this picture of the rash or whatever." Or I'll be able to say, "Look, I think you have an emergency. You really need to go to the hospital." Or you don't need to go to the hospital. And of course, we don't have to worry about malpractice issues. I don't know if I do that in this country, but certainly in court. And I'll have to broach that topic to him to make sure I'm safe doing it. But I don't think there'd be a problem.
I think you're going to see a huge uptick in telemedicine in the United States in the next 3, 4, 5 years.
Yes.
I just think it's a natural part of the progression, you know.
Yes. Well, I think this will accelerate it. This technology, because even though we had a little trouble there connecting tonight, we'll get better. And that the good thing is people don't have to download any software. They've already got they can get the Gmail account, and they can just look at their smartphone and talk to their doctor or the laptop or whatever. It simplifies the process. You know, they asked the head, I think his name's Peter Dorsey, one of the heads of Twitter. How come you come up with these great ideas like Twitter and Square? You know, Square, the technology where you swipe your credit card.
Oh yeah.
That was his idea.
Yeah.
And he says you don't come up with new ideas. You just make the old ideas faster. That's all you do. And he was, you know, that's what he did with Twitter, and that's what he did with Square. It was an old accepted credit card thing, and he just made it easier. And it's the same thing with telemedicine. I think Google Hangouts will make telemedicine easier. I could open a Zambia clinic once I establish communication with this gentleman. I'll say, bring in the patient in. Let's take a look.
Yeah.
It's a start. It's a start, but okay, very good. Okay, Brian.
Well, John, I really enjoyed talking to you.
Yeah, thank you very much. And you know, if you need, if you want to do a hangout with certain groups in urology or whatever, do you specialize, or is it general urology, or?
You know, I'm in a small community. We try to do a little bit of everything, and the stuff we feel that we can't specialize in, we send to University of Michigan or Grand Rapids or whatnot. But we try to do most everything that a general urologist would be able to do.
Okay.
So,
okay. Well, but just let me know if you need anything.
Yeah, I'll tell you, John. One of the interesting things about urology, we have a international urology journal club once a month. So if you follow the hashtag EuroJC on Twitter, once a month, you'll see urologists from all over the world commenting on whatever article we're talking about that month. So that's a great way if you're looking for a global group of urologists. That's probably where I'd refer you to, especially if you're looking for them on social media.
Well, it's the same for you. If you wanted to reach out to those guys, you know, rather than having a journal club, you could have a hangout with those and talk about it in real time with those with the other urologists from. I mean, it's a real joy to meet doctors from other countries. It's wonderful. I don't think I told you the story. I interviewed did I tell you about the Spanish psychiatrist I talked to?
No.
Well, it was a very interesting guy. I don't know how I ran into him. I think he wrote me. That's right, because I do have people writing to my website asking me to write about their application, and I said, well, my first step in writing about it is to interview you on Google Hangout. And Spanish physicians are surprisingly advanced in this technology, because I've talked to a few. And he had tried Hangout because as soon as I mentioned it, he knew what it was. And I talked to him about, you know, he made a program for attention deficit disorder, how to diagnose it early. And he's submitting it to the FDA, etc. It's in the Apple Store, but that's another step from the FDA.
Right.
As you know, it's a step. Once if it's in Apple, doesn't mean it's approved. So anyway, he was discussing it, and during the conversation, you know, it was very interesting. I thought, this is great, man. Talking to a Spanish psychiatrist and a psychiatrist in another country, and while we were talking, an Indian orthopedist who I've been talking to came on the chat, on the panel. His picture was there and everything.
Yeah.
Nishant's his name. He's a spinal surgeon from the eastern part of India. And he started commenting on you know, he kind of got into the flow and asked him some questions. And then as he said, after the conversation, he said, John, I'd like to talk to you. And so after the Spanish psychiatrist signed off, I said, Nishan, what's up? He says, in India, the psychiatrists are considered to be very low in the totem pole. They're just almost not considered doctors. And I thought, wow, to be able to, communicate about things like that, it's fascinating. Just to get the cultural differences, not only educate about the application, but I got some education on the role of a psychiatrist in India. It was kind of interesting.
It's a small world, John.
Oh yeah, yeah, and other docs will want to talk to American docs, and you wouldn't have a hard time, I think, connecting to the urology people over in but you say you don't do too much robotics, just once occasionally, or?
Yeah, so what we do, there's a doctor over in Australia, Dr. Henry Wu, who organizes this, and once a month we have a 48-hour discussion because it's global, and it starts out in Australia, and then it just sort of follows the world as the world turns about whatever journal article is brand new in urology.
Oh, okay.
So if you were going to do a hangout, it'd probably have to be a 48-hour hangout,
Oh, okay.
But people could join. People could join and drop off, I suppose.
Yeah, that's possible. All being recorded by YouTube. I certainly have not heard any restrictions about how long you can go. I think you could leave this on indefinitely. And matter of fact, I thought that would be a good way because I have a friend that does house calls mostly in hotels in Miami Beach. I said that would be a good way to have him open a telemedicine office. Just basically keep the screen open continually, and if a patient calls and doesn't want to see the doctor, he says, just go to my channel and gives the address and stuff. That would be a way to keep a virtual office open 24 hours a day. I really don't think Google cares. I really don't. And I certainly haven't heard anything about them, saying limit of an hour. They really want this technology to go. And just one quick thing before I let you go is that Google, apparently, I don't know the ins and outs of the video technology, but apparently they're really working hard. And I read somewhere where they're probably going to put Cisco out of business in the webinar field, because Cisco is one of the big names now. You've heard of Cisco, right? And
yeah.
Of course, they have a huge company, but part of their company is webinars, and Google seems determined to take over the webinar field, and they think that Google's just going to crush them because they have the technology and they're really concentrating on getting this going. That seems to be the word that most people say, most of the so-called experts. And Google, it's funny, even among social media people, they don't know Google Plus very well. They don't know Google Hangouts very well. They know Twitter, they know Facebook, but when it comes to Hangouts, it's kind of like, well, no. And a lot of doctors say the same thing. Well, no, I've heard of it, this and that. But it's learnable, it's doable.
Yeah.
Because, doctors are experts at learning new stuff. That's all we did in medical school on a constant basis. And you remember being a student and an intern, everything was the learning process. Every procedure was new, and you had to learn it. You couldn't say, I don't like that. No, you had to stop that IV. No, you had to draw that blood gas. You didn't have a choice. You had to learn it, and you did. So it's like a lifetime of constantly learning stuff. And why should tech be different, really?
That's what makes it fun.
Yep, it sure does. Okay, Brian, I'll let you go. I know you have a family and everything. It's a true pleasure. We now have made a successful maiden voyage.
There you go. Send me the link.
Okay, good night.
Good night, John.
Bye-bye.
See ya.
Yeah.